So it is now with great pleasure that I introduce the next session. And I know that this is really of great interest to many of you, and I'm trying to get everyone's attention to keep quiet because it's hard to make sure I introduce Dr. Sokowitz well. Excellent, that worked. It's really my pleasure, and Dr. Sokowitz actually presented last year for us as well. We extended the session a little bit, and we made sure it wasn't over lunch, so that we didn't have the clanking of food, and so that you could really appreciate it and ask your questions. Dr. Sokowitz needs little introduction to many of you here in the room. She's been a tremendous leader in the field in ALS Clinical Trials. She's currently the Chief of Neurology at MGH, and although I think she's so well-deserved of that position, I was quite nervous that she wouldn't have the time to commit, and I'm amazed how she manages. She's always there whenever you need her. She's been a tremendous support in helping build our research programs for the clinical trial studies, and really helped in bringing the right players, the right reviewers. Our partnership now with Niels has been a tremendous way to invest in something I think is making an enormous difference. So really grateful to Merit and for everything she does, and for really the opportunity she gives to her younger clinicians, and what she does for you with the disease. So with that, she's going to give a sort of whirlwind tour. We're then going to ask, and I will introduce Dr. Scheffner, and then hold most of your questions for the Q&A for both of them. Oh, he's doing it all day, so don't feel compelled to go right now. There's apparently a big sign for him just outside the door. He's somewhere outside the door.
Thank you. So thank you, Lucy, for inviting me. I'm very excited to be here. Last year I spoke way too long, so I only have 25 slides and hoping to leave a lot of time for Q&A, but it is a kind of a whirlwind through where we are in therapy development in ALS. So this is a pie-in-the-sky dream. It's not funded, these two initiatives, but this is where I think the field really needs to go. And I really call it two initiatives. One is Treat ALS Today, and the other one's Enroll ALS. We really need to get those great ideas out there in the lab to patients much sooner. And there's a couple challenges, and one is that the drug companies, the pharmaceutical companies, have shied away a little bit from early development in ALS. They're waiting to get involved until we are already through our phase 2 and we have some proof of potential efficacy, and that means there's a hole for funding for those early studies, and that's where foundations and philanthropy are so much more critical now than a couple years ago. There are a lot of great ideas there, and there are drugs that are ready to go into patients today, but we lack those resources. You know, not only has the pharmaceutical company pulled away, but also the NIH funding has been cut for everybody, but also for ALS trials. So I think we need to come up with ways to raise funds to bring treatments to patients today. We also have to develop ways to do this faster, and we have an initiative that we've put a proposal into the ALS Association for to create what we call fast-track sites. So these are sites in our network that have agreed to a central ethics review, so that there's only one review that covers all the centers. That will speed up study startup from 9 months to 1 month. We've done this in other diseases, and we need to do that in ALS. And similarly, to have one contract that covers all the sites, so you don't have any negotiations. And again, you can get things into patients much quicker. I think those are really important things to do. The other thing you really heard about is that we need to understand this heterogeneity and the diversity between patients so that we can be much smarter in our treatment. So that maybe there's X treatment that's only going to work for a subset of patients and another one for a different one. We need to be able to determine that, so we'll get more successes. I call that project Enroll ALS, and that's really related to what was brought up in the last session about there's so much data here in this room and in all our clinics from our patients, and we need to be capturing that, just like you heard from Dr. Bedlack as well, that initiative. So the dream would be that we'd have a project like what exists in Alzheimer's and Parkinson's already, which is that almost every patient, or a large number of patients, when they come to their clinic, we're capturing their clinical data. We're also doing biomarker work. We're getting DNA for genetics. We're doing imaging work, and we're sharing that as an open source so that any scientist or any patient or any clinician can look at that data. There's models for this. Again, it's working tremendously in Alzheimer's. It's working tremendously in Parkinson's, but we don't have the funding source to do this in ALS, and I know this is something ALS Association and others are trying to raise funds for. These two things would really change the field dramatically. So you've heard that the science is just exploding in ALS, and I won't go over the science, but other than to say that it's given a lot of targets and a lot of ideas for treatments, and there's a huge pipeline. We also have a lot of experience in ALS trial design, which means that we have the measures, we know what the FDA requires, so when we have a good drug, we can get to patients quickly. But our challenges are that we're still diagnosing people too late. On average, it takes 12 months. There's ways to do that sooner, but we think we need to do that much sooner, not only for patients, so they don't have to go through a lot of testing and a lot of anxiety, but also that we can get treatments to people sooner. And we need to tackle this disease heterogeneity, because that's what's really driving our trials to be very large and probably are not having that many successes, as you heard from Lucy. So I won't talk too much about biomarkers, but because you heard about it, but just really to thank the many of you who are here that are participating in tons of biomarker studies, and also to ask your help to really get the word out to patients about how important these studies are so that we can understand the disease better and get better treatments. So the Northeast ALS Consortium has really been working together since 1995 to try to develop treatments for people with ALS. We have a great group of scientists that work with our clinicians. In the last 5 years, we've been bringing in lots of patients and patient advocates to our group, which is really tremendous. We've held several sessions called Clinical Research Learning Institute, where we've brought patients and their spouses to learn about research, for us to hear from them about what their barriers are and to bring them onto our teams when we develop treatments and bring them forward. So the other mission we have is to share everything that we do. So when we collect samples, those are available to any ALS scientist, whether you're in academia or industry. When we do a trial, all that data set is shared openly. And we're training new investigators because it can't be done by a small number of people. We need to bring in the brightest and the smartest to ALS and teach them how to design and run studies. And we've now trained 43 people to be principal investigators of trials, and over 10 of them are currently leading trials. So that's fantastic. Again, it just speeds up the whole process. So now I'm going to just switch to where we are in treatments, and I can't talk about all of them, but I'll highlight a few. And then obviously in the Q&A, we can talk about any therapy people want to ask about. So this is what's already in people in different stages. Again, there's some are company drugs, some are academic-led, repurposing drugs on the market for other diseases such as Mcsilatine. Some of them are just, what's the best exercise? What's the best nutrition approach? We're starting to have studies that are only in people with SOD1 or C9orf72, again, trying to get more targeted treatments for patients. So a lot of activity here. But there's a lot of other things that are close and ready to, or good ideas to go into people that either don't have funding yet or need some additional preclinical work. And I'll talk about some of these. The color scheme, the blues, are ones that we have gotten funding for, or close to funding for, and the red one, the Actimara, is one where we have almost all the funding, but not quite. So I'm going to talk a little bit about these in particular. But all the other ones are ones that are great targets, and we're talking to the companies, but we don't really quite yet have the resources for. With the ALS Association, we've been really trying to improve knowledge out there for patients about how you found out about a trial and whether it's enrolling, where it's enrolling. If you have questions about it, who can you call? And so we have an 877 number and an email. And Perry Midori, who's, if you could stand for a second, works, again, with ALSA and Niels to answer those calls and direct them to the right person if she might not know the answer. And we're hoping this works, and also through the webinars to get information out to people. So I want to talk a little bit about the nutrition study, and it's just one slide. So this was a study to try to address, does increasing caloric intake change outcome in people with ALS? There's a lot of preclinical science that suggests that it might. In an animal model, a high-fat, high-calorie diet, extended survival. We know that when we look at large data sets that people who have a higher body mass index have a slower course. So we did a study in 60 patients where people either got a regular calorie diet or they got 30% more calories either from fat or from just a regular distribution of carbohydrates and proteins. And even though it was a small study, we saw a pretty dramatic effect on survival, that people who were on the 30% more diet of just kind of regular distribution of calories did the best. I mean, they had a very profound effect. Again, it's a small study, doesn't mean it's definitive, but it really suggests that there's something today that's pretty simple that people could do. Again, relatively simple, it's hard to eat 30% more, but it's available. We'd like to do a bigger study, actually, and really kind of confirm this, but this is one of those studies there's really nobody there to support. But I think it's an important step forward in ALS. This is the GSK drug, also called azanezumab. Ozanimab. I call it the anti-NOGO-A drug. It's much easier to say. And this trial is ongoing. It's a phase 2b, so it's a large study, 500 patients. We'll have the results at the end of the year. It's led by GlaxoSmithKline. And the idea here is this antibody will help your nerves sprout and regrow. So it's kind of like a regenerative approach. And we all have this protein called NOGO-A in our bodies that prevents nerves from growing or resprouting. And it particularly seems to be a high level of this in the muscle of patients with ALS. So by getting rid of the NOGO-A, the idea is you're getting rid of the inhibitor, and you might promote sprouting of the nerves and their connections to the muscles. So this is an ongoing study, and it's anticipated that we'll have the results at the end of the year. Another study that's currently enrolling is the diaphragm pacing study. So this is a device that is available for patients if you have certain criteria, but we really don't know whether this works or not. Devices are approved very differently than drugs. Drugs, you really have to show efficacy and safety. For devices, often you just have to show safety, and the field is left a little bit not knowing whether this is helpful or not, and if it is helpful, who does it help? In collaboration with John Katz and Jeremy Scheffner, and with funding from many organizations, including ALSA, MDA, and the company that makes the device, Synapse, we're doing a study to try to really answer the question about whether this is helpful or not for people with ALS. Mcsilatine is another active study. So this is an available drug that's on the market for people with cardiac arrhythmias, but that we think has a rationale for people with ALS. And so this is an ongoing study. We're anticipating that we'll have the results in the fall of 2014, so not very long from now. And the idea behind this is that if we look at the motor nerves of people, or motor neurons of people with ALS, they're what we call hyperexcited. They're firing more than they should. And we can measure this in many different ways in people, but also in a dish and in a mouse model. And Mcsilatine is able, at least in an animal model and in the lab, to reverse that hyperexcitability. And so we want to see in patients whether there's any, if it's safe and if there's any evidence of some efficacy. So this is a phase 2 study, 60 people at 10 centers. It's almost done enrolling. I think it's 90 to 95% done with enrolling. It's a short study testing 2 doses versus placebo. Again, we're anticipating the results of that in the fall of 2014. There's 2 active stem cell trials going on now in the United States, and I know you've heard about these before, so I'll just touch on them briefly. One is with a company called Neurostem, where they take stem cells from the spinal cord of a fetus, and they're grown to be kind of nerve-like cells, and then they're injected into the spinal cord of people with ALS. They're in their 2nd study now in patients, and I'll tell you a little bit about that. And the other stem cell trial is with Brainstorm, also called where you take people's own stem cells from their bone marrow, they're called autologous, And they're grown up so that they basically become super secretors of proteins called nerve growth factors that help motor neurons survive longer. So they're really using here the stem cells as a delivery tool to get proteins that might be important for keeping motor neurons alive to the right place. So these are given in the muscle and the spinal fluid. So neural stem, they finished the first phase 1 study, and first, because this was the first time anything was ever injected into the spinal cord of a person. And again, the patients with ALS are really pioneers in many ways. I mean, this is, again, a first time anyone's ever done anything like that. And we're also pioneers in gene therapy trials. It's the first time any gene therapy approach for central nervous system study was really done in SOD1 patients. So in the study, they started really with low doses in the lumbar spinal cord and then moved up to higher doses in other areas of the spinal cord. But as I think people know here, in this study, there was one person who made a really remarkable improvement in their symptoms, and that's shown in the black here. And because of this, there's a lot of debate about what happened. I mean, that's obviously a very good thing, and it's important to try to learn from that. And we don't really know whether it's the stem cells or the immunosuppression drugs that patients were taking to ensure that their body does not reject the stem cells, or neither. It could be something else. But because of this, we wanted to go forward on just testing the immunosuppression drugs, and I'll tell you about that study. But for neural stem, after they proved that this was safe, they're now in the middle of the next trial where they're taking the highest dose they got to in this first study and treating up to 15 more patients and keep escalating the dose. And it's really a dose-finding study. What's the number or the number of cells to use that's safe and that will give the best chance for efficacy. And that trial is almost complete, should be complete in a couple months. So as I mentioned, we were trying to understand why one person got better. And I think sometimes great discoveries are made by observations of single patients. And so it's really important to try to understand this. So we're doing another study with 30 people. And there's everybody gets the drugs here with the same immunosuppression cocktail that is used in the neural stem, and those are the 4 drugs here. These are pretty serious drugs. They're really designed to prevent your body from rejecting transplants. They're used, for example, in kidney transplants. But we know everything about them, and they can be administered, safely, with physician care and nursing care. So in the study, we're taking 20 people who are very early in their illness, and this is really to try to mimic the clinical characteristics of the person who got better. Again, we don't know if that's the important factor, but we wanted to try to do that. And then the other group are people in any stage of the illness and later. And this is really reflecting what we've really heard from our patient advocates who really think that there's a lot of people out there who would like to be in trials, but maybe haven't been able to in the past because of some of the entry criteria. So this is a study that there was no breathing cutoff, and people could be any number of years into the study. And so we're almost done with this. I think we've enrolled 21 people, and we anticipate we'll be done with enrollment in the next 2 months or so, and then we're following people for a couple months. Again, we're looking here to see if anybody else improves like we saw in the neural stem trial. Brainstorm, I hope you can see this. I just wanted to give you a sense of where they are on their studies. This is the autologous bone marrow-derived stem cells. So in Israel, they've completed two studies. So they had a compassionate use program that they treated 4 people with, one who got twice treatment. Then they did an initial phase 1 study with 12 people, where half the people got the cells in the spinal fluid, half in the muscle. And then they're in the middle of the second phase 2 study in Israel, where they're treating another 12 patients, and this time everybody gets both the spinal fluid injections and the muscle injections. And again, they're increasing the concentration of cells in each cohort of patients there to try to really figure out what the best dose is. And in the US, we're just about to start the US trial. It'll probably start in June or July of this year. It does have FDA approval. It'll be 48 participants. And here we're going to use the highest concentration of cells found in the phase 2A study in Israel. And we're going to start looking for preliminary efficacy and, again, continued safety. And in Israel, they're now planning to go to the next step, which is to see, do you need to do repeat injections, not just one time. So the U.S. study will be at 3 centers, UMass Medical, Mass General, and Mayo. And the reasons they're only in 3 centers is that you need to be next to a facility that can grow these cells, and that's actually the rate-limiting step is to be able to grow these cells. It takes about a month in certain facilities that aren't widely prevalent throughout the United States. So that's why there's one in the Boston, 2 sites in Boston were sharing the same facility to grow the cells, and then Mayo had an existing center. So again, that's anticipated to start in June or July. We do have FDA approval, we have IRB approval, but we're now getting the training on how to do this, do the study correctly from the people in Israel who did the prior studies. Another study that we're about to launch is with a drug called, I call it Actimara because I can't pronounce the other one. And this is funded jointly by the ALS Association and an anonymous donor to MGH. And this was the drug that was picked out of a call that we did with ALSA, where we wanted to do phase 2 studies that had biomarkers that could be really driven by being able to tell in the person, did your drug do what it was supposed to do? And so Actimara is an available drug for a type of cancer, but it has a good, interesting property for ALS. So it blocks something called IL-6. IL-6 is an inflammatory marker that's elevated in patients with ALS, but it's not elevated in all patients with ALS. In a small study by Dr. Filia, he measured this in patients and found that there was 2 groups of patients. One who had high markers of these inflammatory markers, including IL-6 in their blood, and another group that doesn't. So here we're really going to look for people who have that signature, and those are the people that would be in the study. We're going to see if the drug lowers that, and if it's safe, and if it has any preliminary efficacy. So Dr. Shafiq Lada at Barrows is the principal investigator of that. We now have the funding, and we have the drug, and we anticipate this will start in the next couple months. We haven't picked the sites yet, but it'll be 4 or 5 sites in the United States. So I want to talk about another new study with a drug called Ratigabin. And this is a really exciting new drug that came out of this stem cell technology heard by Dr. Maragakis yesterday about the ability to take someone's skin cells and turn them back into the stem cell they came from and then into a motor neuron and use that to understand the disease and kind of personalize care a little bit and see if you can find drugs that work in those motor neurons. And he took motor neurons from patients with C9 ALS, grew them up, and found that they were hyperexcited. Basically, they were firing abnormally compared to motor neurons from someone without ALS. And he got down, because he's an electrophysiologist, got down to why they were firing abnormally. And it was a particular thing called a potassium channel in the motor neuron. And then he looked for drugs that can affect potassium channels and found Ratigabin, which is an available drug for epilepsy. It's a relatively new drug for epilepsy, and it does have some FDA kind of black box warnings for retinal pigmentation and urinary retention. But again, sometimes it's better to know what the risks are so that you can do things to try to minimize those. But it's certainly something that's been given to many patients with epilepsy. So this is the first drug that's really come out of this IPS technology. And of course, we don't know that necessarily predicts success, but we're quite hopeful that that might be a way to find drugs for people with ALS. So we now have confirmed funding, and so it did take a while to get funding. So we have a combination of funding from the ALS Association, from, again, an anonymous donor to MGH, as well as the company GlaxoSmithKline and the Harvard Stem Cell Institution. So this isn't an unheard of story in ALS where you need to get like 3 or 4 groups together and to raise the funds to do a clinical trial. And this is the current design. So it'll be 120 participants. Everyone's going to get a skin biopsy because we want to be able to go back and see if people who respond to this drug, assuming some people respond in a favorable way, could we have predicted that from their motor neurons? Now, it still takes a fair amount of time to grow the motor neurons, 2 months or so, so we're not going to wait to screen to pick people based on what their motor neurons look like, but we're going to be able to, at the end of the study, to look and see if that was predictive, and that will help in future studies. We're going to test 2 doses versus placebo, and we're going to look at a bunch of electrophysiology measures to see does it affect that hyperexcitability that we see in patients with ALS, and then clinical course as well, and is it safe? And that study should start probably in the fall of this year. So that was kind of a whirlwind of some activity of some of the drugs. And again, there's a lot more out there, and you're going to hear about Tiracentive from Jeremy. But if you kind of heard the theme, what do we need to do to really learn more about ALS? And really is this biomarkers, and we're starting to get them. We have the electrophysiology ones, we have the spinal fluid one you heard from Lucy, we have these inflammatory markers. So it's like we're getting the information, but to really be confident about this, we need this in a large number of people. And that's why I think this idea of something like Enroll Als, where at all the clinics, we're asking people if they want to be part of this, whether it's giving blood for DNA or doing an imaging study. It'll really help us crack ALS. I just you probably heard the theme of the financial support. I think, funding for research is just hard in general now because of the NIH cuts and the economy. And I think that supporting ALSA and these organizations is the only way to bring these drugs forward. This is just a few examples of studies that have been funded by foundations and philanthropy. The Mcsilatine, the Actimara, and the Ratigabin I talked about. We just learned this week of funding from a private donor for 2 new studies. One, a T-reg, that's getting people's T cells and getting their good T cells and giving it back to them. So we're just starting to work on that. And then another way using gene therapy approach to shut down SOD1. Again, the immunosuppression study is also funded by foundations and philanthropy. The other thing, I know Advocacy Day already happened at the Hill, but I'm sure you asked for this, and even for next year, of really lobbying for NIH funding for ALS. I mean, they do definitely do some. They haven't funded an ALS trial in a while, and we need to kind of keep it on their radar, them and the Department of Defense as well. Thank you. I hope I left lots of time for questions, either now or after Jeremy.
If you want to take a couple, but then let's move on to Jeremy.
Sure. Just a couple. Oh, we have one here and one here.
Sorry, are there any mics in the room?
Oh, they're coming.
I think we're going to stick to 2 because I mean, we probably got the afterwards. But here's one and here's one.
So the use of the Mcsilatine phase 2 will target the sodium channel blockers, correct?
Yes.
So is the hope that that will just prevent the action from the muscle from firing, correct? But is that possible to be used in combination with the drug that targets the potassium channels as well?
Yeah, so we don't know the safety of the combination, but they do act on 2 different causes of hyperexcitability.
Okay.
So in theory, there's a possibility they could be additive. But they're not, even though they're both marketed drugs, there's no indication that they're both used together, so we don't really know what would happen if you give them both together.
And if you could decrease the muscle fire, the action potential firing, and the stimulation of the muscles, would that decrease the symptoms of ALS? That's the hope?
That's the hope.
Okay.
Yeah. That maybe that hyperexcitability is causing damage to the motor neurons and therefore to the muscle, and if we can get rid of it, maybe that would improve it.
There was one question there, and then we're going to move on.
Here's a question. My husband participated in the phase 2 study of NP001, sponsored by Neuraltis, and it ended in 2012. He happened to get the drug. That basically it's something to help possibly delay the progression of the disease. When he finished the trial and the drug pretty much got out of his system, there was a marked progression of the disease. And we also know someone else in the same trial that very clearly benefited from this disease. It seems to have dropped off the map, And can you give any update on the potential of a trial 3 study with this drug?
Sure. So this drug is MP001. The good news is it hasn't dropped off the map, and we're still very hopeful that that will go forward to another trial. So this is a drug that blocks what we call macrophage activation. So it blocks part of the inflammatory system. And in the phase 2 study, it was a small study, but it looked like there might have been a subset of patients who responded. 30% of approximately of the people on the high dose had no progression over 6 months compared to 10% on the placebo group. So it might be that there's a subset of people that respond. So this is a very small company, and they're trying to raise funds in order to go forward to another study. They're also trying to develop a way to identify who those responders might be so that they can do another study in that population. So they're still at it, and a lot of us have been helping them to try to go to larger pharmas to try to get that resources. So that's why it's taken so long, but it's not dead. So that's still hopeful.
We're going to take questions at the end, so please hold your questions, and we're going to do it after Jeremy. Okay? Thank you, Merit. Thanks, Merit, for an excellent presentation. So it's my pleasure now to invite Dr. Jeremy Scheffner to present the next, actually the update of the BENEFIT trial. Dr. Scheffner, too, has been incredibly pivotal in ALS field, and as you will see in your Research ALS Today publication in front of you, was just recognized last week as the Sheila Essie Award recipient, which is a joint award in honor of Sheila Essie, who passed from ALS. Dr. Scheffner, currently professor and chair of neurology at Upstate Medical Center, New York Medical Center, has really also been pivotal in ALS, and it's actually quite a nice combination because the two of them were the founders of Ils, and so really his work in biomarker development has been tremendous in the field. But today he really wears the hat of presenting the BENEFIT study. I also want to really acknowledge Cytokinetics, who have been absolutely tremendous in this trial, in their dedication and commitment to ALS, and their really effectiveness at being quick about communicating it. They really had to analyze data very quickly to be able to present it at the American Academy of Neurology. You've had various news releases. They are here with us today. Jinsey is here, and Tim Miller, and they will be with us at the Research Expo to discuss any further questions as well. But a big thank you to them for being a partner with us in the fight for ALS. And thanks, Jeremy, for presenting the data.
Thanks, Lucy. It's really a privilege to be here and to be able to talk to you about this. I was asked to talk about the BENEFIT ALS trial, and that's what I'll do. But when we're answering questions, Merritt and I will be happy to talk about anything you want to talk about. So I think that this trial, well, this trial is getting more attention on this program than the other trials that Merritt summarized. And I think it's appropriate just because of where things are in the stage of development, not because it's necessarily the best drug for ALS, but it's now at a point where we really have a lot to say about what it might or might not do, and it's been studied in the largest number of patients of the group that Merritt mentioned. And so we presented these results just last week. What I wanted to do before talking about the results is talk to you about what this kind of approach might do, because Tiracentive is in most ways different than most other drugs that have been evaluated in ALS. Most, but not all of the approaches that Merritt summarized have a goal of changing the underlying rate of progression of the disease, identifying something that's going on within the brain or spinal cord of somebody with ALS, and altering the mechanism of action of whatever the process is, and making the disease go slower, or ultimately even making it get better. The goal of Tiracentive is not quite so I don't want to say grandiose. It's not quite so pervasive. because it actually doesn't act on nerves at all. It acts on muscle. And the idea is not so much to change what's happening in the brain or spinal cord of ALS patients, but to take the end organ, which is the muscle that makes you do things, make that work better, and if that is the case, hopefully make people function better and do better longer. So it's an attempt to actually improve function in ALS rather than necessarily to attack the disease directly. And so the cartoon that you see now is a cartoon of what individual muscle fibers look like. Muscle is actually made up of two filaments. There's an actin filament, which is the purple balls and the small purple strand that's running along it, which is a component of that filament. That's called the thin filament. And then the actin filament, which is called the myosin filament, which is called the thick filament, which is composed of a very large set of longitudinal structures, and those yellow kind of oval things which grab the actin and cause the muscle to contract. And there's a nice cartoon that hopefully will play here. So the yellow or orange are the myosin filaments, and the blue ones are the actin filaments. And you can see that those little bulbous structures actually grab one filament and pull it in, and that's how muscle contracts. And tiracentive acts on the blue filaments to actually release, to make it more possible for this contraction to occur and to make the contraction last a little bit longer. So that's the proposed mechanism. And unlike many of the ALS drugs that are hopefully going to affect disease progression, we know that that's what that does. And I'll show you some data to suggest that. Now, there's a similar drug that works on heart muscle that also does similar things. It improves the efficiency of muscle contraction. And this is not the same drug that I'm going to talk about, but it's a similar mechanism, and heart can be looked at a little bit more dramatically than muscles can. So these are ultrasounds of a heart. And so there are two chambers of the heart. The one at the top is the ventricle, the one at the bottom is the atrium, and these are from the same person, either with or without this drug that affects muscle activation. And I think you can see that if you look at the little thing that's flapping in the middle, that's a valve. You can see that on the right, the valve is flapping much more dramatically than on the left, indicating that much more blood is flowing. And if you look at the actual way that those chambers are contracting, they're both contracting more actively on the right. So that in heart muscle, you could demonstrate pretty clearly that muscle can be activated with this kind of approach, and the function can be improved. And the hope is that tiracentive will do similar things to skeletal muscle, which are the muscles that make you move and also help you breathe and swallow. So can't show you the equivalent of that ultrasound, but these are some data from the SOD1 ALS mice showing that in that mouse model, tiracentive does increase activities related to muscle strength. And so if you look at the bottom left bars, the green bar are animals on tiracentive, the gray bar are those on placebo, and you can see that running speed increases pretty dramatically. Another test that these animals are subjected to is that they're placed on the top of their cages, and they're just asked to hang as long as they possibly can until they fall to the bottom of the cage. And then you can see that their ability to hang on in the top right is also significantly and pretty dramatic looking, doing better on tiracentive than on placebo. And in people, we can do similar things. So this is an experiment in normal human volunteers. And what's done is shown in that little cartoon in the top right, where a nerve that causes the ankle to flop up like that, to bend upwards, is stimulated electrically. And this is something that's done pretty routinely in diagnostic laboratories. And you can measure the force of the upward movement of the foot very, very clearly. And the more frequently you electrically stimulate that nerve, the more force that the ankle muscle, the muscle that moves the ankle up, will exert. And this experiment was done with different stimulation rates. So the nerve was stimulated at 5 hertz or 5 stimulations per second all the way up to 25 hertz or 25 stimulations per second. And the force was measured without tiracentive and with various doses of tiracentive. And you can see that on this graph, tiracentive improved the force of this muscle pretty dramatically. So we know it has an effect on the muscle in normal human volunteers and in animal models. Prior to the benefit ALS study that I'm going to describe, ALS patients were given tiracentive either as a single dose or for a limited period of time up to 3 weeks. And in these graphs are plots of how people performed on a number of different tasks compared to the concentration of tiracentive that was in their blood. And so on the x-axis is the concentration, on the y-axis is the performance on these measures. And so going from the top left, maximum voluntary ventilation is a respiratory measure, sniff nasal inspiratory pressure is another respiratory measure, muscle strength is muscle strength, and slow vital capacity is another respiratory measure. And you can see that on all of these measures, if you compare performance as a function of how much tiracentive is in somebody's blood, there is a positive and significant relationship suggesting that tiracentive improves this. So this is suggestive data. It's not proof that tiracentive is helpful. And in order to get a further idea, the benefit ALS study was conducted and just recently completed, and we reported the results, I think, last week. Time is flying. So this was a much bigger study of up to 700 patients, and I'll show you the details. And the design is that people were screened, and if they were eligible, they all started with a week of a fairly low dose of tiracentive. So everybody got tiracentive for a week. And the reason that this was done is that we knew at this point that tiracentive caused dizziness in a relatively sizable minority of patients. And so we wanted to make sure that patients that couldn't tolerate the drug because of dizziness didn't go on to get randomized to participate in the trial. And so if the patients did tolerate it, after that, the interval between that 0 to 1 week, then they were randomized to either receive an increasing dose of tiracentive up to a maximum of 500 milligrams a day, or placebo. And they were evaluated with the ALS Functional Rating Scale and with measures of breathing and strength at visit 0 and at visits 6 and 7, as well as visit 5. And so we had a number of measurements both before starting the drug and at 4 weeks, 8 weeks, and 12 weeks after being on the drug or placebo. And so this just shows how the patients were distributed. There were 711 patients who were enrolled in this study, and a little bit more than 100 patients really had side effects that made it not advisable for them to continue. So they did not continue after that 1 week of open label drug. So there were about 600 patients that were then randomized between tiracentive and placebo. And one thing you can see right away is that there were some issues with tolerability. In the red boxes, you can see the people who withdrew, and you can see that 3 times as many people withdrew from the study on tiracentive as compared to the ones on placebo. And the reason for withdrawal really were all based on adverse events or experiences that were felt by the investigator or the patient that made them not want to continue. They were not serious in terms of life-threatening, but they were enough to make people make the decision not to continue. This just shows that, in general, the patients who were on placebo and were on tiracentive were very similar on many of the aspects of the disease that we look at before things start. They were similar age, similar sex ratio, similar weight, and similar in the outcomes that we measured. And here is a little bit about how people tolerated the drug. So the way this study was structured is that after people went through their open label 1 week period, they gradually increased their dose from 250 milligrams a day to 500 milligrams a day over several weeks. And so the blue bars are the people who got to the maximum dose of 500 milligrams a day. The yellow bars are the medium dose of 375, and the blue bars are the lowest dose of 250 milligrams per day. And you can see that on the placebo side, pretty much as you'd expect, people could take as much placebo as they were asked, and it didn't do any, and they were able to tolerate it very well. And for the most part, they didn't drop out, although there is some slight decline over the course of the study. On the tiracentive side, you can see that patients did get up to that 500 milligram maximum expected dose, but not everybody. Really only about 55% or so of the patients were able to tolerate that maximum dose, and about a quarter of the patients could tolerate the middle dose of 375, and about a quarter stayed at that low dose of 250 per day. And that the numbers of patients who stayed in the study for all those visit numbers, which is up to 12 weeks, was significantly less than the people who were on placebo. So that there was something about the drug that made some people drop out. Here's the data. And so the primary outcome measure, the one that was specified as being the measure of at least potentially primary importance in this study, was change in ALS-FRS. And on that measure, this study did not show success. There was no statistically significant difference between the rate of decline on ALS-FRS as compared to placebo. And in fact, the placebo patients did a little bit better than the people on Tiracentive with respect to this measure. And I think there are some reasons why that I'll talk about in a minute, but that's what the data showed. So if you look, if you look at the bottom numbers, you can see the slopes for Tiracentive, slope for placebo, and the difference between the slope. And so the difference between the slope, which is a difference between the rate of progression, is what was looked at in this analysis. And you can see the p-value is 0.15 or almost 0.16. In general, we like to see p-values of 0.05 or less before we decide that something is statistically significant. Vital capacity, which is something that many of you who are patients have done on a visit-to-visit basis at clinic all the time, is a breathing capacity test. It's what the task is, as most of you know, is that you breathe in as much as you possibly can, and then you blow out as far as you can, and the volume of air that you blow out is your vital capacity. And on this measure, there were some pretty dramatic differences. So if you look at the slope for the tiracentive decline, it's about 0.039, and the slope for placebo is about 0.9. So the rate of decline on vital capacity was less than half as great on tiracentive as it was on placebo, which is a pretty exciting result, I think. And the p-value for that, how statistically significant it is, was 0.0006, which is very significant. Other measures of respiration, though, of breathing, were not consistent, and this is still a puzzle. Maximum voluntary ventilation is a test of how much you can breathe in and out rapidly over about 12 seconds, and on that task, there was a slight trend to benefit tiracentive, but it was nowhere close to statistically significant. And on a measure of inspiratory force, which is basically you take a probe, you put it in the nose, and you ask somebody to sniff in like that. That measure, which is a measure of diaphragm force in some way, was also not statistically significant, but it was in the wrong direction. The placebo folks did better than the tiracentive folks. So this is still somewhat of a puzzle. Strength, we also looked at a measure of muscle endurance, and just if you look at those plots, you can see that those points are just everywhere. And so this was a very hard thing to measure, and it was quite variable. It favored tiracentive, but the variability of that measure made it impossible to say anything about whether that was really a significant effect. And then we looked at muscle strength. And muscle strength is an important aspect of ALS progression, as I think most people will agree. And if you look at the slope for tiracentive, it was 0.11. The slope for placebo was 0.27. So again, the placebo patients declined almost 3 times faster than the tiracentive people did on this measure. And this test was quite statistically significant as well. So this summarizes the measures that were really obtained in this trial and where they fell in terms of favoring tiracentive or favoring placebo. on the right, the points on the right of 0 suggest an effect that's positive for tiracentive. The points on the left suggest the opposite. And those error bars, if they cross 0, that means it's not statistically significant. If they don't cross 0, they are. And so you can see that ALSFRS had a difference between placebo and tiracentive that favored placebo, but it wasn't statistically significant. Vital capacity, or SVC, favored tiracentive and was quite significant. MVV, which is another respiratory measure, favored tiracentive a little bit, not close to significant. SNP went the other direction, but also wasn't significant. Grip fatigue was that very variable measure that favored tiracentive, but was very variable. And then strength favored favored tiracentive as well, and was significant. So before I go on, this is a mixed result. And what does that mean to people in this room? And I mean, I think the real answer is we don't know yet. And there's more work to be done. But if you look at the results of the last 12 clinical trials that were more than just 20 to 30 patients, but we were really multi-center clinical trials that involved hundreds of people. The last time any of those trials showed any statistically significant effect on any measure was Riluzole in 1992. So this study does show more statistically significant effects on measures that you would expect to be important to patients with ALS than any trial since then. Now, does that mean that this drug is ready to go forward to approval? I think the answer to that is clearly no. That there were problems in tolerance, and we need to understand what's with the ALSFRS. But I also wouldn't be hopeless about this. I think this is a very hopeful, although not conclusive trial. So what do we know about why things happen the way they happened? This is a listing of the adverse events or negative things that patients experienced while in this study. And so the columns are everybody together, people on placebo, and people on tiracentive. And the symptoms that are colored are the ones where there's at least a 5% difference between the tiracentive and the placebo group that suggested that the drug was causing these effects. And so you can see that dizziness, fatigue, nausea, and headache were all the most common, and they all clearly happen more often on patients on tiracentive than placebo. And there were a number of others as well. The blue symptoms are ones that are GI related and also favored, or not favored, but occurred more often in tiracentive than in placebo. And that'll be important in just a second. And this just shows you how people did in terms of completing the trial on the placebo arm and on the tiracentive arm. And you can see that clearly more people dropped out on tiracentive. That's the bottom curve. Also clearly, most of that happened pretty early. So by about 4 weeks into the trial, if you were still taking the drug, you had a very good chance of continuing to be able to take the drug. Most of the dropouts happened in that first 4 weeks. So why did I mention GI or digestive system adverse events? Well, it turns out that patients clearly lost more weight on tiracentive than they did on placebo. Now, it is a tendency for patients with ALS to lose weight over time. And you can see that the black bars show the rate of decline of weight in the patients in the placebo group between week 0 to week 4 to week 6 to week 8 to week 12. And at every one of those time periods, the tiracentive patients in general lost a little bit more than twice as much. Now, this isn't a huge amount. At 12 weeks, the tiracentive patients lost on average 1.7 kilograms, which is on the order of 4 pounds. So it's not a tremendous amount of weight, but there's a clear difference here. And it's also clear, which on the right-hand side of this slide, that the people who lost weight were the ones that had the GI symptoms. And so in both placebo, which is on the left, and tiracentive, which is on the right, patients were divided into those who had GI adverse events that they reported and those who didn't. And the bars in blue show the weight loss in the patients who had GI side effects, and the bars in red show the weight loss in the folks who didn't. Then you can see that both on placebo and tiracentive, if you had a side effect of nausea or diarrhea or other GI effects, you lost more weight. And if you didn't, whether you were on placebo or tiracentive, you lost very little weight. And then if you combined how much people lost with how they did on the ALS-FRS, you get an interesting story. So there are 3 comparisons here. So three sets of blue and red bars. And this is the change in ALS-FRS on placebo and in blue and on tiracentive in red. And so you can see at week 4, if you lost more, sorry, I explained that wrong. So this is each one of these is the comparison between tiracentive and placebo, whether you lost more or less weight. So if you look at the bars on the left, if you, at week 4, if you lost more than the median, so more than the average amount of weight, then you tended to do much worse on ALS-FRS on tiracentive as compared to placebo. If you lost less than the median amount of weight or average amount of weight, there was almost no difference between tiracentive and placebo at week 4. At week 8, the same pattern was true. You lost more weight. If you lost more weight, you did worse on ALS-FRS if you were on tiracentive than placebo. But if you lost less than that average amount of weight, you actually numerically did better on tiracentive than on placebo. And the same thing was seen on week 12. Now, that difference is not statistically significant. None of these are statistically significant. But at least it suggests an explanation for why people did worse on the ALS-FRS on the tiracentive group, which seems to be at least a good hypothesis that people who were on the drug had more GI side effects that caused them to lose more weight, and those people who did lost more weight did worse on the ALS-FRS. So what can we conclude? The first question is there anything interesting here? Is there a potentially important effect on people with ALS? And my view is the answer is yes, that this is the first study to show a statistically significant difference between strength and in strength and breathing that we've essentially ever had in a study this size. And the fact that patients actually had more adverse events that in many ways felt worse and still did better on breathing and strength makes that an even more powerful comparison. Second question is, the way this was given, the way this drug was given in this study, was it adequately tolerated? And I think, for the most part, the answer has to be no. That many more people dropped out on tiracentive than they did on placebo. So we have to figure out why that is and whether there's something that can be done about that. And the people who stayed on had some significant effects that seem to have contributed to them functioning less well on the ALS-FRS. And so to go forward, one has to at least try to figure out a way to take those side effects and make them less severe. And then what about why do we see this sort of funky set of results on ALS-FRS? And I think the reason for that, at least in large part, has to do with the GI side effects and weight. So next steps are really as yet unknown. Whether this drug gets developed further will depend on how money can be raised for a further study, whether the expert community and the patients are enthusiastic about going forward. But if it does go forward, I think the big questions are, can the drug be given in a way that makes it more tolerable? Maybe by having the ramp up in dose much more gradual, maybe by having the end dose that we try to get people to be on slightly lower, maybe by paying special attention to weight and doing things to make sure that people don't lose weight. All those things are reasonable things to consider. And Cytokinetics, who was incredibly responsive during this study and who it's been a pleasure to work with, is thinking about those things. But I think that what we're left with is a very promising, not conclusive, interesting set of results that are worth considering further. So thanks very much.
Thank you, Jeremy, for a very clear presentation on the results. And I'm going to ask both you and Merit to help address questions. We've got about 15 minutes before our break. And I do believe that the lady right in front of me, if she still has a question, is first, because I've denied her question on 2 occasions now. If we can just get a mic there, and then we'll move to other questions.
Excuse me.
Thank you. My question is, do you know why bulbar palsy was excluded from Brainstorm?
I can answer that one. So it is true that in the upcoming study, it's excluded. And I think there's a couple reasons. One is that the treatment is given in the muscles in the arms and legs. So we don't think that will get to the bulbar muscles. That's one reason. And then it's also given in the lower spinal fluid. And we think it's most likely to go for the motor neurons in the spinal cord and not necessarily up in the bulbar area. That's one. And the other is that it's a very small study. It's only 48 people. And the reason it's small is really tied to how the cells are grown. That it's not something you can do in hundreds of people. And so in this study, we wanted to get a group of people that were more similar to each other so that we could have a chance of getting a readout. I think if it goes further, then it'll be, in the next study, it would be expanded to everybody, knowing that we'd have to deal with the question of whether the cells would reach the bulbar muscles.
Thank you. Question here? Oh, one moment. There's one behind here.
Okay, thank you. First of all, I appreciate the presentations. And as I review online and look at the studies and what they entail, there's always a caveat near the end that says you cannot have participated in any other study. And I understand the need for purity, moving from one study to the other. And you don't want to mix up potential results and the effects. But it leaves me with a set of tarot cards in front of me on a table, deciding which one may or may not have an effect for the cause, which is to look for therapies that will help ultimately develop a cure. And so I don't know if there's a way to be able to take part in more than one or not, but I think that there are a group of people that want to take part in as many as possible, and it's not like you have an endless supply of people who are available to take part. So I just wanted to throw that out there, see if you had any thoughts.
That's a great question. I'll take a crack at it, and I'm sure Merritt will have something to say as well. So in general, it's not that it's not considered an exclusion if one has participated in a trial previously. So many patients, if they otherwise meet the criteria, participate in one trial, stop, are off that experimental drug, and then go on to another one. There are times when that is excluded, and those are the cases where the treatment itself may have effects that last far beyond the duration of the trial. For example, stem cells. If somebody gets surgical implantation of stem cells, even though the trial may end, that doesn't mean that the effect, positive or negative, couldn't persist for the lifetime of the patient potentially. We do, as a general rule, not allow people to participate in more than one experimental trial at the same time. And you're right, there's a finite number of patients, and it would be great to be able to do this. The trouble is at least several-fold. One is these are experimental drugs. They're not treatments. And so not only do we not know all the negative effects of single drugs, we know almost nothing about the negative effects about the combination. And in general, medically, it's much better to know about the potential side effects of a drug individually before you start messing with them together. The second is that for the most part, we don't have great biomarkers for our results of our studies. And so if some combination actually is effective, we don't know whether it's one drug, whether it's the other drug, whether it's a combination, unless you can look at them individually first. And so this isn't an ALS-related problem. I mean, this is pretty much the way drugs have been developed in almost every disease. There's a whole host of diseases, such as AIDS or cancer, where combinations of drugs ultimately turn out to be the best way to deal with things. But those drugs are always evaluated sequentially, either individually or on top of something that the people already know works. And to some extent, we're already doing this in ALS, in that almost every trial that we've done includes patients who are on riluzole. So we're effectively looking at the combination of something we know works plus the experimental agent. At this point, it's the best way we can come up with.
Great. Here there's a question, if we can get a mic here, and then while you have the mic, please.
Merritt, I was wondering if you could tell us a little bit about the Brainstorm trial. I know that 2 of the sites are in Massachusetts, and we're getting questions in the chapter office as far as, is enrollment still open or is it closed at this point? I know it's a small trial.
Sure, I can answer that. The first thing I wanted to say one comment about the last one, very briefly, in that we're at an incredible time now. It's great to have so many choices. It's very hard for people because it's not like we know which trial is going to be better than the other. But it wasn't that long ago when we saw patients in clinic and we didn't have any trials. Now I think we have a table filled with about 15 consent forms, and we've actually hired a research nurse just to have like a place where people can go and hear about all the research studies. So it is hard to make the choice, but it's certainly better to have choices. So that's the good news. You know, for Brainstorm, again, because we just got IRB approval and just got FDA approval, we have not done any site patient selection. We're getting trained in the study soon, and what we're going to do is we keep a list of people who are interested, and we're going to start contacting people based on the eligibility.
So if we get inquiries, should we refer them to meals, or what's the best way for us to refer them?
We're going to put a phone number and an email on our website. For now, you could do it to Perry, who's the email on our website. Absolutely. The other thing I'll just say about Brainstorm is because there's an unusual inclusion criteria that people have the illness more than 1 year and less than 2 years. One of the things that we would like to do is start by looking at our people who are close to that 2-year cutoff and start to approach them first. But we will approach everybody who's told us they're interested.
There was a question here. I don't think there's a mic here yet. Can we get a microphone here? And then if you can go ahead, Steve, with your question.
Kind of on this theme of exclusion criteria, a lot of the trials do have the vital capacity over a certain amount that's required. And I'm assuming that's a safety issue, but then also wondering about the onset of symptoms or diagnosis and so on, because that's a question that comes up a lot. Why are patients excluded, for instance, who have had, in many cases, symptoms for more than 24 months? And so I guess just if you'd speak in general to exclusion criteria, please.
Sure, I think we could both tackle that. There's a lot of input that goes into inclusion-exclusion criteria. I mean, the FDA weighs in, the ethic boards, the company, the investigators. Often it's driven by the drug. You know, if there's data that the drug doesn't work later on in the illness, that would be one reason why we'd push for earlier. And sometimes it's because you only can do the study in 50 or 60 people, and you need to find a way to get a group that's more homogeneous so that you can get a readout. We do try to have studies that have varied inclusion criteria. You heard from Jeremy on Tiracentive. That one had no cutoff for how long you've had it. And we have the immunosuppression with no cutoffs. So we're trying to, but sometimes you have to have some criteria so that that it makes sense with the drug that you're treating.
I'd just add a little bit, as Merritt said, there's a whole host of drugs that are being tested right now, and I think a real advance is that we know enough about what we think these drugs are going to do that we really are modifying inclusion criteria to best test these individual drugs. One thing that what you're talking about in large part is patients who have had the disease a long time or who have progressed to a certain point often feel excluded from trials. That's a completely real feeling, I know, and very powerful. For trials that last 9 months to a year to 18 months, most often these trials at this point don't look at survival as the primary outcome because that's a very inefficient way to do things. We look at a variety of things related to patient function. And death turns out to be not only a bad thing for all considered, but it's terrible for the trial because you lose that data. So that there's a compromise that has to be made. You know, if you enroll a patient into a trial, you want to be as confident as you can reasonably be that that patient is likely to be able to complete that trial. So that's one reason why those why those criteria are set that way. But for shorter trials, for example, the Tiracentive trials, the earlier trials actually had no vital capacity cutoff and no duration of disease cutoff. As things went on and we needed to lengthen the trial longer, those criteria became a little bit more stringent, more severe, but you know, those were the reasons.
We have a question here.
Okay,
and then
for Dr. Scheffner, did I hear you say at the beginning of your talk that there's another medication which is currently available which may have similar properties?
No, so the Cytokinetics, basically the focus of their company is developing drugs that affect muscle. And they have a drug that affects cardiac muscle, heart muscle, that is also in development. And that's the result of that. That drug had the effect that I showed you on the echocardiogram. That drug actually, as far as anybody else knows, has no effect on skeletal muscle, but it's also an experimental drug in development.
question here.
Hi, thank you for your presentation. I wanted to ask your advice or opinions on the diaphragmatic pacing systems. We have done a lot of research on that, sat on some webinars. I know that there's a study taking place. I think the downside of that study is that for every 2 people that get it, 1 doesn't, and it is paid for as a humanitarian device through insurance. So I think enrolling in our area, in talking to the trial folks, you know, it's a little bit difficult. But I really wanted to know your opinion on what you have seen the effectiveness, because the groups that we belong to, patients we've communicated with on PAL's private Facebook sites and caregivers' private Facebook sites, they seem like they're really happy that they had made that decision. And of course, the company research looks fantastic, but that, you know, so I just would like your opinion.
So I'm the PI of the randomized trial, so I'll take a crack at that first. So first, what do we know about this going in? There was a study and that's the one that led to the humanitarian approval, where patients were selected according to specific criteria and implanted with the device, and there was no control group. There's several things we know about that. One is that it was pretty safe in that there were complications of the surgery, but most of them were manageable. We also know that in terms of our measurement of breathing capacity, vital capacity, between the time that patients got the implant and the time that they were next studied, vital capacity dropped a ton. So that there was a period during the period after the operation where things fell. And then it appeared that if you just looked at the rate of decline afterwards, that there was a suggestion of a signal that suggested that people decline more slowly. So that leaves people who look at who evaluate data very uncertain. I think there are certainly patients who give reports that they did very well for a very long period of time on the procedure. Now that I'm the PI of this study, I get emails from a whole host of patients, and I've gotten some emails just as you said, of people who are quite happy. I also have quite a few emails who said, "How can you be studying this? My wife or husband got this device and was dead in 3 weeks." So both kinds of experiences are out there. Now, the difference between this study and other studies is not that there's a placebo group, because most of our studies have placebo groups. The big difference is that you know if you're in the placebo group because we're not doing sham surgeries. But in Tiracentive, in Empower study, in Dexpram and Pexol, in all the studies that Merritt mentioned, people are on placebo. And this is not suggesting what the results of the DPS study are going to show, because I'm very hopeful that we'll see that it has a place in treatment in patients with ALS. But if you take all of the studies done in the last dozen years and look at how people did, by far the best group to be in is placebo. We've been much better at making people worse than we have in making people better. And so it's very important for people to be in trials. We'll never figure out anything unless people volunteer for trials. But the idea that it's always a bad thing to be in the placebo group is not necessarily true. And so that's the conversation those of us who are trying to enroll patients into this trial have to have with patients, which is that we are hopeful. We really hope that this is an important piece of the treatment of ALS, but we don't know. And down the line, when the results are analyzed, it may be that you may be happy if you're in the placebo. We have to have people willing to take that gamble.
So now I'm sorry to the two that I know are eager to ask a question. We are on a very tight schedule because this room has to be reconfigured for lunch. I know Merritt and Jeremy would be very happy to speak with both of you individually. So I would ask you, first of all, to just give a quick thanks to wonderful panel, both presenters. Thank you, Merritt and Jeremy. And I encourage you now, please all head to the expo. We'll be there. Merritt and Jeremy will make their way there, and we'll be here at least briefly, and Jeremy for much of the afternoon. So thank you, and bring your questions to us there. Thank you so much. It was great. I'm very glad.